Okay, let's go ahead and get started. Good evening, everybody, and welcome. And thanks for joining us this evening to the third Las Vegas Medical District Town Hall discussion. My name is Dr. Jeffrey Roth, and I'm currently serving as the president of the Clark County Medical Society. We're the co-presenting sponsor, along with the City of Las Vegas, of this evening's Town Hall. It is entitled tonight, How Technology and Innovation Are Advancing Medicine and Saving Lives in the Las Vegas Medical District. This event has been planned in collaboration with the Medical District's many partners, and a special thanks to Valley Hospital Medical Center for underwriting the reception that will follow this discussion. So stick around for that. It should be good stuff. I'm delighted to see so many people in the audience from the local medical community, from the City of Las Vegas, and from our many esteemed medical education institutions who together are shaping medicine and directing the future here in Southern Nevada. I'd also like to thank a few people, Cassandra Munoz and Heather Kane, who are here tonight on behalf of Congresswoman Adita Titus, Gabrielle Everett, who is here on behalf of Congresswoman Susie Lee, and Aga Pinkerton, and I hope I said that right, I'm sure I'll hear about it if I didn't, who is here tonight representing Senator Jackie Rosen. So thank you. Did I get it right? Okay, good. I'll stop now. I should just sit down and quit while I'm ahead. The Clark County Medical Society is pleased and honored to help convene this fine group of community medical leaders as the co-presenting sponsor of tonight's Town Hall. At the Clark County Medical Society, our mission is simple, to serve the needs of physicians, their patients, and the Clark County community with responsibility and integrity. We, Clark County Medical Society, advocate here in Southern Nevada in order to preserve the patient-physician relationship and encourage the delivery of quality health care within the community through a variety of programs, events, and education. I encourage any of you who are interested in learning more about what we do on a daily basis to please go ahead and check out our website, clarkcountymedical.org, and please consider joining us for our 65th annual board installation dinner and awards ceremony coming up on the 1st of June this year. And in the audience is Dr. Daniel Burkhead, who will be taking over the reins on June 1st. Lucky man that he is. All right. It is now my honor and privilege, especially as a long-term Las Vegan, came to town in '77, went to Chaparral High School, grew up with the Running Rebels, et cetera, as most of us did. My honor to introduce Mayor Pro Tem Lois Tarkanian to share a few words with us. Councilwoman Tarkanian has been a huge proponent of the Las Vegas Medical District, and she is highly supportive of all that we are trying to accomplish here. Councilwoman Tarkanian.
I wish I could run like those rebels ran. Yeah. Good evening to all of you. I'm pleased to see such a nice crowd here tonight in support of our city's expanding and growing Las Vegas Medical District. I am especially proud to represent Ward 1, where this is happening. It is exciting to see the medical district bringing bringing all the new innovative medical that we can, and to increase the quality of life in our valley. That's what the key is here. We can expect to hear tonight from several medical district partners, including Dr. Aaron Ritter from Cleveland Clinic Rouville Center for Brain Health, who will share information on important brain research and clinical trials being done at the Rouville Center. And Dr. Chowdhury Asan from UMC will share information on advanced heart care. And finally, Dr. Leslie Broder from Valley Hospital Medical Center will share with us exciting developments about the Da Vinci robotic surgical system. I looked at that while I was sitting on the other side, and I said, I think Da Vinci needs company. He looks a little lonely over there with arms outreached. And finally, Dr. Anshu Shaw from Steinberg Diagnostic Medical Imaging will discuss advances in mammography and digital imaging. You know, there are so many individuals and groups here tonight that I would like to acknowledge a few of them who have helped us. A special thanks to tonight's sponsors, the Clark County Medical Society, and especially to Valley Hospital for underwriting and hosting the cocktail reception following our discussion. I know many of you are busy medical professionals caring for our citizens and preparing the next generation of medical professionals. So thank you very, very much for taking the time to come to this meeting tonight. Also, a thank you to those who are joining us on KCLV Channel 2 or online. And I'm looking forward to hearing from our presenters tonight to get updates on key medical institutions that are bringing first-rate medicine here to our valley. Together, the 4 hospitals, the 7 institutions of higher learning, the 2 digital imaging centers, and the Cleveland Clinic Lou Rouville Center for Brain Health are helping to create a true academic medical center here in Las Vegas. Here, the new UNLV School of Medicine will work hand in hand with medical providers to develop a coordinated center of medical excellence. The goal of the medical district is to enhance greater collaboration amongst the various institutions and facilities to advance medicine in our community. And I want you to know that the city has put a lot of time and a lot of money already into getting things prepared so you will be able to have the first-rate technology assistance or whatever you need there. We're working really hard on that. You have the support, and you have the strong support of our Mayor, Carolyn Goodman. The Las Vegas Medical District also has the potential to influence and upgrade development of all kinds in and around the area. It's not just development related to medicine, and that's because the doctors, the medical professionals, medical students and professors who work at facilities in the medical district all need places to live, all need places to grocery shop, to enjoy a cup of coffee, and to drop off their dry cleaning. It's amazing the new businesses that are looking to come into this district and to provide for those who will be moving here or working here. By infusing the area with more people and highly educated population of people at that, the neighborhood services needed to support those individuals gives rise to new residential and commercial development, and we're already seeing in the city evidence of that with new developments on the drawing board. And then finally, a very exciting plan is already in place to better physically connect the medical district to downtown Las Vegas. Last year, the RTC and the City of Las Vegas were awarded a grant from the U.S. Department of Transportation to launch what they call GoMed, which includes 4 autonomous shuttles with 23, I should say autonomous shuttles with 23 smart transit shelters that connect downtown to the medical district. This will especially help seniors and those with disabilities to move easily between downtown and medical facilities within the district. And Ward 1 has 4 senior centers, senior homes close by the medical district, and it's going to help them also. I think the majority of people who look at what we're doing will feel incredibly exciting for our city. I'm delighted that you're here tonight to learn more about technology and innovation in the Las Vegas Medical District and to hear inspirational stories about advances that are making all the difference for Southern Nevada residents. Personally, I know we have very fine doctors here in the area, but I also know we don't have enough, and I know that there are specialties which have none. I myself and members of my family have gone through situations where UMC or Valley has recommended we go to Los Angeles for what we need because we don't have that specialist here. but I do know that we are going to have them here. We're going to be able to serve whatever need we have, and we're going to be great. So you, every single one of you, are part of what we are doing. And anything that we do that's good, just remember, it's together that we will see this happen. And I want to say welcome tonight. That's it. Thank you.
Thank you very much, Councilwoman Tarkanian. I couldn't agree more with what she said. We found that where there's investment in medicine and physicians, other businesses follow, and it is a tremendous stimulator for the economy all around. It's just a good thing. All right, on to the program. Without further ado, our first presenter tonight is Dr. Erin Ritter from the Cleveland Clinic Lou Ruvo Center for Brain Health. Please join me in welcoming Dr. Ritter for an update on cutting-edge clinical trials being conducted at the clinic. And I take a half a second, as I go out to northern Nevada or other places outside Nevada, I always point towards the Lou Ruvo Center as a really crown jewel and as an example of how excellent medicine can flourish in the desert. So with that, Dr. Ritter.
I can do here. All right. Good evening, City Hall. Thanks for having me here to talk about clinical trials on Alzheimer's disease. We always start with the profession where we haven't had a new medicine approved since 2002. So our advances in technology are going to come through clinical trials. And we've had a lot of exciting breakthroughs over the last couple of years, and we hope to translate them into much more effective treatments for our patients. It's always important to underscore the importance of dementia. Dementia is all around us. It seems to be a natural state of the human condition. 50% of people over the age of 80 will eventually develop dementia. The effects of the global impact of dementia are enormous already, and they're going to continue to grow as people live longer all over the developed world. We're going to see a quadrupling of the number of people living with dementia by the year 2050 if we don't have more effective treatments. So the time for us to act is right now, and I'm happy to be part of an organization that is engaged in finding new and more effective treatments for Alzheimer's disease. This is a particularly striking slide, I think, in my field, and it shows that since a new medication has been approved, and last one was in 2002, we've made a lot of advances in other diseases, but in Alzheimer's disease we haven't. So, as I said, this gives me purpose every day. We're moving to earlier diagnosis because we think more effective treatments will come earlier in the disease course. But this is a sobering slide for everyone that works at the Lou Ruvo Center for Brain Health and anybody that has a family member diagnosed with dementia. This is important to the state of Nevada because in the last Alzheimer's Association annual report, Nevada is the second fastest growing population with dementia, only second to Arizona. So this is an issue that's going to hit our state particularly heavily over the next decade, and we need to be prepared to take care of both patients with dementia as well as the family, because dementia is not a single disease. It doesn't just affect one person, it affects the entire family. And that's what's so nice about our organization. We're focused on not just the patient that is diagnosed, but also the support of the family members and caregivers. All of our social services are provided free of cost by philanthropy. We are a Medicare institution, so we take patients with Medicare and all different types of insurances. This is the most important slide, I think, for everyone to realize that everyone with a brain is at risk for Alzheimer's disease. People ask this question all the time, is Alzheimer's a genetic disease? We don't know the answer to that. It seems to be a combination of factors, something in our environment as well as our genetics. But we're all at risk. And so this is an important emergent public health issue. So as people know that have had family members diagnosed with dementia, we have medicines. The medicines themselves are not that effective. We can see over the course of a year, we can kind of slow the progression of symptoms. We're not doing anything to stop the disease in its tracks. These are slides from two FDA-approved medications for dementia, rivastigmine and galantamine. They were both approved in the late 90s. And we can see that the effects over time are rather minimal in short-term studies, and these are not effective medications to stop the disease in its tracks, so it's what we need. These medicines work on chemical systems in the brain that are affected by Alzheimer's but are not part of the key pathological processes. The good thing is there seems to be hope that the disease is leaving some areas for us to attack. So we know from longitudinal studies that have been going on for 15 years that the proteins that we think are causing this disease are starting to build up many years before the onset of symptoms. So we now have a conception of Alzheimer's disease is going through several stages. One with normal cognition, followed by a stage of mild cognitive impairment, and ultimately to dementia. So a new conception that has recently been put forward in the field is attacking the disease at the earliest stages before the brain damage has been done. Most clinical trials, particularly those done at the beginning of the 21st century, were done in people with dementia already. The damage has likely already been done, and the ability to slow or stop the progression of the disease has already passed. So with the advances in technology, primarily in diagnosis, we are able to better identify people at high risk for developing dementia, and then using in treatments that may stop or slow down the disease. So this is where our technology is in diagnosis. In the past 15 years, we've had approval for an amyloid PET scan that detects the accumulation of amyloid in the brain that can be detected before the onset of symptoms. It's not yet approved by Medicare or any insurances, but it's used primarily for research purposes. So at this point in our history of Alzheimer's, we don't have to wait for the pathology to make the diagnosis. We can make the diagnosis during life, and that's an exciting advance in our technology. We have an amyloid PET scan in our facility. Unfortunately, there is no ability to have the ligand produced in Las Vegas, so it is shipped from either Phoenix or Southern California, but we do approximately 200 amyloid PET scans every year in our research program. This is probably the most exciting thing that's come out in clinical research in Alzheimer's disease. In 2016, in a phase 1b study conducted primarily in Europe, a monoclonal antibody directed against amyloid was shown to reduce the accumulation of amyloid in the brain, essentially turning a positive amyloid scan into a negative scan. So folks that were in the study, diagnosed based on their positive amyloid scan, were given a monoclonal antibody directed against amyloid, and by the end of the study, 75% of them had negative scans. Did that translate into clinical success? We don't know. The study wasn't powered or long enough to detect the clinical benefits. So phase 3 studies testing monoclonal antibodies against amyloid are ongoing, and we have 3 of them at the Brain Center currently. So we have this ability to offer this to patients that are diagnosed early with Alzheimer's disease to participate in clinical trials that may usher in a new era of Alzheimer's disease therapeutics. In addition, we're learning so much more about the disease every day. I think the number in 1977, there were approximately 15 papers published every year about Alzheimer's disease, and the last number was 25,000, and I think over the past 3 years. So there's been a lot of advances in the number of publications directed toward understanding the pathology of Alzheimer's disease. So there are new targets that we think may be more effective that have not even been scratched the surface in testing whether they were able to stop or slow down the disease. The Lou Ruvo Center for Brain Health, well, let me go back really quickly and say we are testing many of these compounds at our facility, and clinical research is a big effort at our center, and we offer this to most of the patients that come in that meet criteria to participate in clinical trials. This is a slide that shows us that if we're able to slow down the disease by 5 years, I think the number is 50% reduction in the global prevalence of Alzheimer's disease. So if we're able to have a sort of impact on the progression of symptoms or the onset of disease, we can have a huge global impact and make a big difference all over the world in terms of people living with dementia. So this is what we're shooting for, and we've never been able to accomplish that in Alzheimer's disease clinical research. So this is our target, slowing down or preventing the onset of symptoms. So I'm really proud of our center. Dr. Jeffrey Cummings has been the pioneer of the Brain Center, along with Larry Ruvo and Camille Ruvo and their philanthropy in supporting our center. We've grown into one of the largest clinical trial centers in the country for Alzheimer's disease, as well as Parkinson's disease and multiple sclerosis. We've completed about 70 clinical trials. We have anywhere from 20 to 30 ongoing clinical research trials at one time, and we're particularly involved in therapeutics for Alzheimer's disease. This is the annual global pipeline that we produce every year that looks at all the different medications that are being tested for Alzheimer's disease, and the circled compounds are the ones that we're testing at our center. So you can see we're heavily represented. We're very proud to offer this opportunity to patients. That makes us stand out from regular practice when it comes to just diagnosis of Alzheimer's disease. We can offer something to patients and their families that may help improve symptoms. We have a very active publication group. We've had over 300 peer-reviewed publications in the past 9 years. I think that number is even higher. I'm sorry, Nicole. I think we're up to 500. And we have ongoing studies, not just in Alzheimer's disease, but in multiple sclerosis, Huntington's, PSP. We had the very first study in PSP, Lewy body, and frontotemporal dementia. So we're very excited to bring clinical research in the neurodegenerative space to Las Vegas, and we're hoping to partner with all medical providers in the city for referrals and encouragement to participate in clinical research, because that's the only way we'll be able to find more effective treatments for these common but dreaded diseases that we face. So thank you for your time, and I'll move on to the next presenter.
All right. Thank you, Dr. Ritter. Next up is Dr. Anshu Shah, who is the Director of Women's Imaging from Steinberg Diagnostic Medical Imaging, who will speak tonight about Steinberg's high-tech mammography and digital imaging technology. Dr. Shah.
Thank you, Dr. Roth. Good evening, everyone. It is a pleasure to be here today and talk to you all. Steinberg Diagnostics has been consistently strives to bring the most cutting-edge imaging technology to Las Vegas, and we have been serving the Las Vegas community for over 30 years. In fact, we have 2 out of our 8 offices located right here in the Las Vegas Medical District. So today I'm going to talk to you about mammography, specifically 3D mammography, also called digital breast tomosynthesis. It is probably the most revolutionary technology that has come to Las Vegas and has really dramatically changed how we interpret and look at mammography. I'm going to get the clicker here. So why get a mammogram? Why get a 3D mammogram? Well, first of all, the Pristina unit at Steinberg Diagnostics, which is our 3D mammography unit, offers the lowest dose of radiation possible. It's equivalent to the 2D mammogram that we're getting now. It was designed with patient comfort in mind. So we actually had a patient named Christine Marshall, who is a breast cancer survivor and one of the first patients to get a 3D mammogram here in Las Vegas. And she described her experience as being very peaceful. And I can tell you, I haven't heard many people say that peaceful and mammogram in the same sentence, so I thought I would share that with you. Our mammograms are very high quality, where they're going to be available at every single one of our mammography locations. And we actually have 4 subspecialty trained women's imagers, including myself, that read a bulk of the mammography in our practice. So why get a mammogram? Well, getting a mammogram obviously is to find breast cancer. Unfortunately, 1 in 8 women will develop breast cancer over the course of their lifetime. In fact, this year alone, 250,000 women will die from breast cancer in the United States. So we want to do what we can to find breast cancer and treat it the most quickly and the most effectively as possible. So let's look at some of the risk factors for breast cancer. Obviously, family history, something most of you are aware of. If you have a mother or grandmother, obviously you're going to be more concerned about it. There's also a genetic predisposition possibly involved. There's also a personal history if you have breast cancer, and also there's multiple environmental factors that can contribute to breast cancer as well, including obesity, alcohol use, even smoking. But what I really want to emphasize on this slide is that 80% of women who are diagnosed with breast cancer have absolutely no risk factors. It happens completely out of the blue. So if you have a risk factor, definitely get a mammogram, but if you don't, still, you need to get a mammogram. So not only do we want to use our mammogram to detect breast cancer, but we also want to use our mammogram to find breast cancer when it's its absolute smallest size. In fact, if we find breast cancer when it's less than 2 centimeters in size and localized to the breast, our 5-year survival rates are over 99%. We have the most incredible surgical techniques in this day and age, and also 4th, 5th, 6th generation chemotherapy drugs. So the treatment options for patients are at the most we've ever had. And you can see as you go further, as the cancer grows, as it's detected more later, and it's actually left the breast and metastasized, those survival rates go down pretty dramatically. So when should you get a mammogram? Well, unfortunately, there's a lot of confusion right now about when to get a mammogram. I can tell you the American College of Radiology, as well as the American Cancer Society, recommend that we get an annual mammogram for a patient with an average risk of breast cancer beginning at the age of 40, period, and that's when everyone should get a mammogram. There are situations where we would recommend different schedules. For example, if you have a genetic risk, or for example, if you have symptoms, if you have a palpable lump, if you have skin changes, if you have nipple retraction, things like that, you want to go talk to your doctor, and potentially we'd send you over to get a mammogram much sooner. The other thing I wanted to let you know is that family history. If you have a family member that was diagnosed with breast cancer at the age of, for example, 40, we would recommend that you begin your screening mammogram at the age of 30, 10 years prior to that person's age of diagnosis. So how is a mammogram performed? Basically, we do 2 views of the breast, top to bottom, side to side. We compress the breast for approximately 5 seconds in each view. And we will do extra views for patients with implants because we want to see the tissue surrounding the implant. We'll do about 4 extra views. So what does a normal mammogram look like? So this is a patient. These are 3 different patients that have completely normal mammograms. The mammogram on the right, which is going to be a scattered mammogram, you can see very little glandular tissue. The one in the center has more dense tissue, has more white. It's considered heterogeneous. And the mammogram on the left has a very dense glandular tissue. It's more white. It's sometimes we refer to that as a snowstorm appearance. It's just so white, how are you going to see anything? So now you know what a normal mammogram looks like. Well, what does a breast cancer look like? Well, there's many presentations for breast cancer, but the 2 most common presentations are a dense white mass. I'm going to show you right there. It's a dense white mass with spiculated irregular margins. That's what we're going to look for. And you can appreciate how difficult it would be to see that dense mass in a woman who may have that snowstorm breast, right? The other form of breast cancer that we look for is these things called microcalcifications, and those are little grains of salt that actually develop in the breast tissue. They can be a very early sign of breast cancer called ductal carcinoma in situ, and they're actually the most common presentation of breast cancer. The other thing I wanted you all to know is that mammography is the only imaging modality we have to see those microcalcifications. You can't see them on ultrasound, you can't see them on MRI, and that's why mammography will always be the gold standard for the detection of breast cancer. Nothing replaces it. All right. Well, let's talk about 3D mammography now. So what has 3D mammography brought to the table? It's not only revolutionized the way we read mammography, but it's also increased our detection rate of breast cancer by over 41% in patients with dense breasts. And that is amazing. That's going to be, that's increased our detection value considerably. It also reduces our callback rate and also reduces our false positives. Callback rate meaning if you come in for a mammogram and the radiologist calls you back for additional views. Well, with 3D mammography, we're able to make such a confident diagnosis on your original mammogram that we don't need to call you back. We don't have that issue with false positives. And also, we're not providing the patient with any more additional radiation with the 3D mammogram, and we're also doing fewer follow-up tests and fewer biopsies. So let's look at a 3D mammogram versus a 2D mammogram. So the image on the right-hand side, which I'm going to point to over here, is a heterogeneous breast. It's got a pretty moderate amount of breast tissue. The image on the left is is also a 3D mammogram, but it's the same patient in the exact same view. So what I want to do is show you the difference. If you envision in your mind what a 2D mammogram looks like is a loaf of bread. All right, I want you to envision a loaf of bread. You're looking at it, okay? When I want you to envision for a 3D mammogram is that loaf of bread, but now I can actually pull out slices of that loaf of bread, and I can look at each slice and examine them one by one. And we can see behind dense breast tissue. We can see in front of the dense breast tissue. So we're able to analyze the mammogram in much more detail. And let me show you how we do that. Can you play the video, please? This is a 3D mammogram in live motion. We actually run the cine while we're interpreting the mammogram. And as we're going through, you can see that spiculated lesion. Pop up right there. I know it's kind of subtle for all of you sitting in these chairs, but for a radiologist, it's almost like a big neon sign with an arrow pointing at it that I'm like, you know what, we need to call this patient back and I'm worried about it. So that's what 3D mammography has done in terms of our ability to detect breast cancer. All right, there are going to be times when we are going to call you back for additional views. In this patient, on the image on the right, you're going to see a dense little spiculated lesion, and we're a little worried about that. So we called this patient back and said, we need to do some extra pictures. So what we do is we do a compression view of that particular area. And the reason we do that is we're trying to spread out that tissue. We're trying to make that area of speculation go away. So when we're compressing your breast, we're not doing it because we're trying to hurt you or we're trying to make you uncomfortable. We're doing this because we're trying to make that cancer go away and make that area look normal. And in this case, this patient, you can see that area completely goes away. She's going to come back for her yearly mammogram and have nothing to worry about. Compression also decreases the motion and also gives us clear pictures. So what if you do have an abnormal mammogram? What does that mean? Well, 8 out of 10 times, that's going to be still a benign finding. You're not going to have anything to worry about. If we do consider that there's something concerning there that we need to follow up on, we'll do some additional imaging. We'll do some ultrasounds. We'll do an MRI, and sometimes we'll even consider doing a biopsy for a definitive tissue diagnosis. All right, well, that's all I have for you today. I just want to let you know that we are going to have a virtual reality glasses here in the reception area for you to actually try on and walk through an actual mammogram and see what it's like. I am very passionate about mammography, and I encourage you all, especially all you women, to go and get your mammogram. And all you men, please let all the women in your life know how important getting a mammogram really is. Mammograms save lives, and I see that every single day when I go to work. So I'll be available for any questions, and thank you for having me today.
Thank you so much. Our next presenter is Dr. Chowdhury Ahsan from UMC, who will speak to us about the hospital's advanced heart care programs and technology. Dr. Ahsan.
Good evening, everyone. I thank the leadership of City of Las Vegas and the leadership of Clark County Medical Society to invite me for this presentation. I'll share with you the story of one of our patients. He kindly consented to tell you about this story. So he came to us in the hospital. He's 49-year-old with chest pain. And then soon after coming to the hospital, he coded. Ventricular fibrillation, cardiac arrest, and he was resuscitated in the emergency room, was in cardiogenic shock. And this was the EKG, the tracing of the heart, that's showing that he is in the middle of a heart attack, and he's not doing well. He's intubated now, and in this situation, the national database now showing us a mortality over 60 to 70%. This is a dire situation where we really need to unload the ventricle because the heart needs some support and do the revascularization therapy. That means opening the artery and restoring flow. So we rushed to the cath lab, and we now have the technology that we can put a device in the left ventricle, the main pumping chamber of the heart, and unload the ventricle, and then you're looking at the artery, the front artery is closed, and we do the balloon angioplasty stent as we did the unload of the heart and give support. And then subsequently, this is the device. It has a pump that goes in the main pumping chamber and as a rotor, and then it moves the blood into the aorta and then unload the ventricle, which is really in trouble at this time. So once we do that and then get the stent and the blood flow restored, we buy time in favor of the patient, and we are seeing much better outcome. These patients may sometimes need other devices. We now in UMC has the technology to do the pacemaker, for example. This is the very smallest pacemaker in the world now that we can put in the right ventricle and without any generator in the front of the chest. So I just saw our patient last week. His kidney is recovering, he's doing well, and we now think that he may not need any renal replacement therapy and making good progress, and we'll follow that up. So many of the patients may not be that lucky, and they may have residual damage, and the LV, the left ventricular dysfunction, that may need defibrillator therapy, resynchronization therapy, which we have now, and get the guidelines-directed medical therapy so we can improve the heart function and get the patient going. In future, we need to look for devices that we are now sending our patients from the whole state to California or Utah for the portable or movable left ventricular assist device. But we now have established the heart failure clinic at University Medical Center, and we need your support for getting this program going so we can make this LVAT program in the city. And then we can think about, as we dream, for even getting the heart transplant program in Las Vegas. So this is something that we are developing in UMC, and we also do the education. This is a big part. We established the cardiology fellowship program, which is the only program for cardiology fellowship in the whole state. We started 2015, and this is our third year that we will be graduating fellows. This is a 3-year program, and that is something that we need. Now, we are involved in research, and this is one example I'm showing you that how it can be really helpful to actually give insights about the care in the state of Nevada. So we looked at the database and then see how the ST elevation, myocardial infarction, these patients, when they present, how they do by the way they present in terms of geography. So if the patient presents in an area that there is no access to healthcare versus someone who is lucky enough from here to UMC, for example, and has full access to the healthcare, then how is the difference in the outcome? And in one way, I can assure you that you are in the city of Las Vegas and the geographically in good area, then the in-hospital mortality that we have in the city is actually comparable to the national mortality statistics. However, this is really pathetic to see that if there is no access to healthcare, and many of these areas in the state of Nevada, there is no access immediately, their mortality can be as high as 20%, which is not acceptable. So we are actually taking this to the state, and we are collaborating with the American College of Cardiology and American Heart to see how we can expedite this healthcare, and we can make sure that there is access to the advanced healthcare, and then we can reduce the mortality to these patients. So we are doing this along with University of Nevada, Las Vegas, UNLV. We are collaborating with the university, and the fellowship is under the UNLV, and we are looking at the research, the education. We need to educate our future doctors, and we are fully committed to that. And we have interdisciplinary meetings. We have the Level 1 Trauma Center, and these are outstanding guys. We work closely together. We have the GI Fellowship, Gastroenterology Fellowship, recently started, also in critical care. So together we are trying to build a program that will ensure education research, and we can take the care level for the city and for the state to the level that our patients do deserve. Thank you very much.
Terrific, thank you. Our final presenter tonight will be Dr. Leslie Browder from the Valley Hospital Medical Center, who will provide us with an update on the Da Vinci robotic surgical system. And thank you to the Da Vinci people who brought in their $1.5 million toys to go ahead and let us all see, and then actually let us go ahead and play with them a bit. So thank you for doing that. All right, Dr. Browder.
Hi, I'm Leslie Browder. I'm a colorectal surgeon here in Las Vegas. I actually moved to Las Vegas when I was a medical student. I went to University of Nevada School of Medicine. I moved here in 1997 when I was a third-year medical student. I did a 7-year residency at UMC through University of Nevada School of Medicine, which 2 years were dedicated to research. And then I went away and did a fellowship in colorectal surgery. And I came back as soon as that was done and joined Dr. Thornton, who was our first colorectal surgeon in Las Vegas. And I was the third one. I can tell you now that we have 9. So in the last maybe 4 years, we've grown colorectal surgery. If you look at Colorado and you look at Denver, they have over 30 just for Denver. So that gives you an idea how far behind we were. And coming in as a third colorectal surgeon, I think my first clinic I saw 25 patients. I was with the University of Nevada School of Medicine when it was still UNSOM, and then I left and went to private practice, and I'm currently with the Women's Cancer Center of Nevada, and I see male patients too. I'm the only one in our group that does, because colorectal surgery is both male and female. I'm double board certified in colorectal surgery and general surgery, and when I came back here in 2007, 2008, it was my mission to make minimally invasive colon surgery a reality. We were, I could say, dabbling in it before then, doing some what we call hand assist procedures. It means you blow up the patient's abdomen and put your hand in through a special device, and you call it laparoscopic. But it just doesn't have the benefits that true laparoscopic or minimally invasive surgery has. This is kind of my life, what I operate on. This is a picture of the colon. It goes from the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and rectum. We take out portions of this colon when there's disease. There can be cancer, which is preventable with colonoscopy, but I also treat diseases such as ulcerative colitis, Crohn's disease, diverticulitis, and a variety of benign diseases as well. So all of these sections of the colon, when we remove them, we try to put them back together. Okay, so you heard about ostomy bags and giving people ostomies. That's usually because they either have a very low rectal cancer and it can't spare their muscles that provide control, and that's called an abdominal perineal resection. But most of the times we can get patients' colons back together so they have normal bowel movements like they did prior to having disease. This is what I tell my patients. You have to have surgery. We have to remove your right colon. There's two ways to do this. There's an open way and there's minimally invasive. Open means we cut down the middle around the belly button like it shows you on the left side of the screen. We do it with our hands, remove the colon, the mesentery, and the lymph nodes that go along with that colon, and then put you back together and then sew you up. The other way to do it is minimally invasive. And when you talk about minimally invasive, there are two ways to do minimally invasive surgery. There's laparoscopic and there's robotic surgery. There's pros and cons to each one. The con of minimally invasive surgery is really it takes a little bit longer in the operating room. The benefits of minimally invasive surgery, laparoscopic and robotic, are patients lose less blood. They have less pain. They get better faster. There's less infection. There's less chance of wound complications such as hernia after these types of surgeries. So all of those things with open, there are more of. The only thing that it does is save you a little bit of time in the operating room. I tell my patients that a normal right hemicolectomy will take me under an hour if I do an open procedure, usually about 45 minutes. It takes me about an hour and 15 minutes to an hour and a half to do it robotically. So it's negligent time. It's more time for me in the operating room, but it's less time for my patients in the hospital, less time healing, greater chance for them to go back to their jobs, or if they need chemotherapy, to get back to chemotherapy, to get on something that'll help cure the cancer. So this is a picture of what laparoscopic and robotic surgery it looks like. So I tell them the difference between laparoscopic and robotic surgery. Surgery is still the same. In fact, it's the same surgery you do open. You're just doing it through little incisions. We put a variety of cannulas or ports into the patient's abdomen, blow the patient's abdomen up so we have a working space while they're asleep, and we either do laparoscopic, which the instruments are kind of like my arm. They're stiff and they make one motion usually, and it's this motion. Or we can do robotic, where we can put an instrument in like this, and this instrument can do this and can move even better than my wrist does. That's the difference. The robot doesn't do the surgery. The surgeon still does the surgery. The difference for me is I don't have to have somebody hold a camera and help retract, because I'm in charge of the camera, retraction, 4 instruments with the console. So I'm able to control what I want to see with the camera, what I want to retract, and what I want to operate. So I can move things around myself by using my legs as well as my arms. So that's the difference. This is a picture of somebody healing with an open abdomen. This is a picture of somebody having part of their intestine or a big open operation done. You cut down the middle and you sew it back up and it hurts. And patients used to spend 4 to 6 weeks recovering, if not longer. This is a picture of what minimally invasive surgery looks like from an abdominal procedure. This is not gallbladder or appendicitis. We have to put about 4 to 5 holes, and this is what it looks like after you're done taking out somebody's right colon instead of the picture on your left. The picture in the middle shows you the planning. So it shows you, well, we have ports in to do minimally invasive. That's actually robotic, and I know because the ports are metal. But the incision down the middle is the plan for the open procedure, and the incision down at the bottom would be if a woman was having a hysterectomy. That would be the typical incision that they would make, or the bikini line incision. So what's the history of Da Vinci? Da Vinci was created by Intuitive Surgical. They gained FDA approval in 2000. In 2000, they were doing mostly urological procedures, so prostatectomies were their big ones. After that, gynecology came into play in about 2006, 2005, 2006 with FDA approval. So women were getting minimally invasive hysterectomies. They were getting some of those done, and rightfully so, laparoscopically, but robotics became a thing for gynecology. Since then, we've expanded. We do colorectal, general surgery, head and neck surgery, so we can do transoral surgery with this device. Believe it or not. We can also do transrectal surgery with this device. Gallbladders, hernia repairs, nephrectomies, taking out somebody's kidney for kidney cancer, taking out a part of the lung for lung cancer, cardiac surgeries as well. So it's really expanded, and they've recently started to do pediatric surgery. That was something that wasn't indicated early on. So when I got to Las Vegas, people were doing some minimally invasive colon surgery. Now we're just talking about taking out colon and putting it back together. I started laparoscopically because there wasn't a robot except at Sunrise Hospital that had, and it was being used by urologists and gynecologists. And it was 2 of these robots before, so 2 other versions of these robots. So in 2009, I did the first non-urological, gynecological, and no cardiac. So I did the first colon resection, and I actually did a patient that had rectal cancer. And I had been doing this, like I said, with laparoscopic skills, but needed to see down into these pelvises. Men's pelvises are like looking down into a can of soup, Campbell's soup. They're small and they're tiny. Women's pelvises are wide because we have babies, and they have to be wide or the baby couldn't be born. So doing a woman's surgery is pretty easy laparoscopically, but doing a male pelvis with a rectal cancer that's been radiated and the patient's had chemotherapy and you're trying to see down between the prostate and the rectum is difficult. And in fact, Dr. Thornton came into one of my cases one time and he stood at the screen and he was just staring at the screen. And I said, "What you doing?" He goes, "I've never seen that before." Never seen what? The plane between the prostate and the rectum. He'd only felt it. And we couldn't really see it laparoscopically because of the camera. So it adds a lot. It adds a lot to what I do. I currently have done over 450 cases on the robot now. What do patients need to know? If you're a woman getting a hysterectomy, you're a patient that's going to have part of their lung removed, a colon cancer, or diverticulitis, or Crohn's disease, you have to know that you have options, that you have an option for open surgery or minimally invasive. And that's your right to have those options. A lot of people don't know. They just don't know that there's this technology. Ask your physician. You know, you should have a board-certified surgeon doing your surgery. Ask your physician, ask your surgeon, how many of these have you done? What's your outcomes? What are the risks? They're going to tell you. A good doctor, a good surgeon is going to tell you the downsides and the upsides and tell you the whole story. Ask them when you're talking about robotic versus laparoscopic, because this is where it really sets us apart. I told you before, robotic, laparoscopic, same kind of pain, same kind of healing rates. Ask them what their conversion rates are, because that's the single most different in doing laparoscopic surgery with the instruments that do this to doing a robotic surgery. I can get into anybody, I can go to the right side, up by the liver, over to the spleen, down to the rectum, and get to all those quadrants using this and not have to open the patient, not have to convert to an open procedure. Conversion isn't bad if you can't delineate somebody's abdominal contents and you're worried about injuring something. That's not a bad thing. But there are surgeons that say, yeah, I do minimally invasive, and they put the camera in and then they open the patient. So patients need to know that. And in Las Vegas, there's over 100 robotic surgeons. If you need a hysterectomy, there are plenty of benign hysterectomies as well as cancer surgeries being done in Las Vegas on the robot. One of the providers in town has done over 1,000 procedures on the robot for hysterectomies. There's 29 systems now in the Las Vegas Valley. When I started training, we had one. And then Summerlin got another robot. Now they're showing up at outpatient surgery centers for gallbladders and for hernia repairs. So Las Vegas has them. So everybody tells a story about a patient, and I'm going to tell you my story because I was actually a patient about a year ago. I had a severe anemia and found out that I needed a hysterectomy for a very large fibroid uterus. And I have a busy practice. I do over 600 cases a year. I'm busy. I have a lot of patients. And so I needed to decide what I was going to do. Was I going to have an open procedure? Was I going to have a laparoscopic procedure? Was I going to have a robotic? And I left it, I talked to my surgeon, and they needed to do what was good for me. And she said, you can have a robotic procedure. I had my procedure on Friday morning. I was home Saturday before noon. Sunday, I went with my husband to Costco to do shopping, but I didn't lift anything. Dr. Kushner, if you're listening. By Wednesday, I flew to Seattle because my annual meeting was in Seattle, and I figured if I was laying around and couldn't operate, I probably should go get my CMEs. I got back from that on, I believe, I got there, when I was back to work in 9 days after a complete total hysterectomy. I took pain pills, never. I had narcotics in recovery and no narcotics after I left the recovery room. So the only thing I couldn't do for 6 weeks was ride my horse. I had to give that up for 6 weeks, but I am a testimony to it. I had no pain. In fact, the only thing that hurt was the area where we have an insufflation port, and we also use it as an assistant port. And the robot arms don't go through that port. Human instruments go through there, those laparoscopic instruments. That was the only pain I had where somebody was helping retract on that one port site. So this is the team that I chose to do my surgery. I was fortunate enough to help start the program at Valley Hospital, I think 2015, 2016. They now have 2 robots. Back then, we were only doing gynecologic oncology and colorectal surgery. Now we have multiple specialties and added the second robot, and it's growing fast too. And this is the team that makes it happen. We have first assists, we have 2 nurses, and a tech. And that was our this was our first team. Now we have 2 rooms going, so we've added more people, but that was who was in my room when I did my surgery. And I'm lucky enough to have gotten to start this program and continue to work there. So thank you.
That was great. Thank you so very much. We're now open to taking questions from the audience. We have staff members from the Clark County Medical Society present to collect questions from the audience for our speakers. Now, I know I'm in a room with doctors, so please write legibly if you can, and a little bit big because now I have presbyopia, because all of a sudden I'm one of the older guys in the room. While we go ahead and get those questions up here, we'll go ahead and I'll start a little bit of the dialogue. Dr. Browder, you went ahead and you put up a slide with 2 surgeons at 2 different robotic machines. How often does that happen? Is that still going on? Where are we with that? And do we have a second microphone? Okay.
So we are able to use 2 consoles for training purposes. So when I have surgeons that come to my room to learn the system, they can actually, they don't operate on the patient because they're here visiting, but they can sit at the system and see the same thing that I'm seeing. These screens up here are not the high resolution 3D. What you see in the cockpit or is the real thing. We also use it for training residents. So I can sit with a resident, and I've done this, you sit with a resident and you hand the controls over to them, or you hand them one instrument. and you let them do part of the case. And if you don't like what they're doing, there's a button and you push it and you get everything back. And it freezes their robot. So that's what we use 2 consoles for training purposes. And if nobody else is using it, then my medical student can sit at it and watch the surgery through 3D.
That's spectacular. Thank you very much. And the next question I have is you've told us a little bit about how you might see this expanding. We started with prostates and urological and gynecological, and now it's in pediatrics. Do you see this in neurosurgery? Do you see this in skull-based surgery? Where do you see the robot going?
I think it's going to expand into more into transoral and transorphous surgery in terms of the newer robot that's already out that I've test drove maybe 3 years ago. Da Vinci is eons, and they're so ahead of the game. Their new robot looks like it's one arm that comes down and 3 instruments, including the camera, come out of it. So it truly looks like it's this big, and you have the capability of having the 3 arms in it. So it'll be useful for transoral, getting down into lung. They have another machine that they brought up for biopsying, doing lung biopsies transorally, and transrectal surgery, which is doable on this, but very cumbersome, very difficult to get all this instrumentation down in somebody's bottom.
Outstanding. No, thank you.
The other thing that we do with it is that we can identify blood supply. So if somebody has a tumor in their kidney, a urologist can actually give a patient a dye, and it can light up the tumor and the viable kidney, so you're not taking out the whole kidney. In colorectal, I use that imaging to, when I take out part of the colon and I want to hook up vascularized to vascularized tissue, I put the dye in the patient, which is called icy green, and I flick a button on the Da Vinci, and it takes me to a different modality, and it shows me blood supply of the colon, so that I know I'm putting 2 pieces of bowel together. The old way of doing it was cutting it and watching it bleed, but sometimes you would cut it and it would bleed a little bit, and your attending would say, oh, it looks great, but it could have just been venous back bleeding. It may have not been arterial bleeding, and that is a cause of leaks. So when you put 2 things back together and you get a colon leak, that's a devastating course for the patient and the surgeon.
Terrific. Thank you.
And they're
very much.
developing more to look at ureter, to look at different systems. So we may not have to put stents in somebody's ureter. We may be able to give them a dye, flick a switch, and see where their ureters are. Avoid injuring the ureter.
Spectacular. Thank you very much. So, any questions from the audience so far? All right. If not, yes, sir.
Here.
America, yeah?
Silicon Valley.
Wow.
Yeah. Spectacular stuff. So, yes, sir.
I have 2 questions. For us civilians here, can somebody tell us what where the street definitions are for the medical district that everybody's talking about? That's the main thing. And also, all of the technology that all the doctors have spoken about, is any of that being shared with the VA for helping soldiers and veterans? Those are my 2 questions.
So yeah, a couple things. I should speak for Dr. Brown, and I shouldn't. Is a lot of this stuff came from the military. Actually, Dr. Colonel Satava, who you may or may not know, from DARPA, which is basically he says he has the best job ever because it's like going to Q's office all the time, but he was a surgeon. And basically, what the whole idea was is you didn't really want your surgeons in Afghanistan or the front line, et cetera, were in harm's way. What you wanted them to be is Walter Reed going with a robot like this, and so they're not in harm's way. Further, when you talk about manned space flight to Mars, and somebody has a hot appy on a space trip, now what are you going to do? And again, nobody's done surgery in zero gravity, but you don't want to have a surgeon on the Mars mission, or maybe you do, but basically you would want to have something like this, and we've seen that in Antarctica, where folks had to go ahead and do biopsies and surgeries on themselves. So basically a lot of that, the mindset came from the military and came from space exploration and that sort of thing. So, and as far as the VA goes, I think they're always intimately involved in a lot of research projects because they're usually intimately involved in medical schools, et cetera, et cetera. So that's my understanding. And again, Dr. Browder, am I?
So I get a fair amount of consults from
Oop,
the VA.
microphone,
I
yeah.
get a fair amount of patients that I see from the VA because they don't have a staff colorectal surgeon. And so I offer this to the VA patients, of course. They are, I know that they were planning, I don't remember where my rep is, but they were planning on getting a robot out there at some point, because there are some very good general surgeons out there, and you don't have to be a colorectal surgeon to necessarily do these procedures, and it's useful for hernias and things like that as well.
That's great, thank you.
And
So.
the medical district
So yeah, the medical district question, I'm a little fuzzy on the exact locations. I just kind of see where the light poles and they have little flags on them. But mostly it's in this area here where we're going to have UMC as the major clinical hospital for what was University of Nevada School of Medicine and now UNLV School of Medicine, along with the Valley system, along with other things that are going to come on board. So this is a very exciting time for this corridor. And again, Councilwoman Tarkini isn't here. She would obviously go ahead and answer this better than I. However, they have lots of plans, again, for access. It's not just access to care, are there enough doctors here, but can you actually physically get to your doctor's office? And so I think there's a lot of plans on that to get people here and have world-class care here in this particular area. And this has been going on for years, is okay, we want world-class care, we want the Lou Ruvo Center, we want Children's Heart Nevada. Where are we going to put these folks? And so that decision got made a while ago. Can we go ahead and make a center here? So I can't give you the exact definitions by streets, but that's the kind of overall concept. I hope I answered that. So okay. Any other questions, sir?
Hello. My name is Will Bradley, and I'm an airline pilot and a patient at the VA. My brother's a pulmonologist practicing in the best place a pulmonologist can practice in northern Kentucky, right? He's surrounded by smokers. Anyway, I thought I'd bring up one thing, and this is not meant disparagingly at all. It's a true concern. I recently moved my mom here, who's in an assisted care facility, and she said, well, where am I going to go to the hospital if I get sick? And I said, well, you can't go to the VA. That's only for us veterans. And I will say President Trump has very much straightened out the VA, where I actually trust them now. And so I went to Medicare.gov, and I entered looking for hospital ratings. I was shocked at what I saw. Valley Medical Center, 1 star. UMC, 1 star out of 5 stars. And Medicare rates hospitals on mortality, safety of care, readmission, patient experience, effectiveness of care, timeliness of care, and efficient use of medical imaging, along with 57 other factors. What is going on here? I'm really shocked that the highest hospital in this valley is rated 2 stars out of 5. So I'd just like some feedback from physicians on that, please.
No, I appreciate that. There's a couple things, especially some challenges with the VA system, as are anywhere. And we doctors are products of the VA system because basically every medical school is affiliated with the VA. And I've trained at many of them, and some are terrific, some not so much, et cetera, et cetera. I actually am proud of the VA system here. I think they have a good system. They have some good docs. And the patients that I hear from actually really like it. And most often, as you know from Las Vegas, people are here from elsewhere. Okay. On the subject of your mom, there's a few factors that go on there. Okay. One is the fact that we are tremendously underserved as far as physicians and the physician-to-patient ratio. If you ever try to get into a rheumatologist office, it's like, you know, finding hen's teeth. Okay. There's 7,000 licensed physicians in the States, 5,000 MDs, 2,000 DOs. To get to the 50th percentile, we would have to license 2,500 more docs. So when there's an access issue, an access problem. The other thing too is there's always been this stigma in Las Vegas of, oh, wait a minute, it's all casinos and it's all that sort of thing. But when we start to recruit physicians and we say, well, wait a minute, we have the Smith Center here, wait a minute, we have art, oh, we have science, we have all that stuff, then they start to perk up, and there's opportunities here. So to answer your question, it's a matter of recruitment of physicians and the supporting structures around them. I think that's part of it. I think the hospital systems are really doing well to try to catch up and enhance and embrace things like the Da Vinci system. There is really some very good docs and some good care here in Nevada and in Las Vegas, and especially now, we're about to have 3 medical schools in Clark County. And if somebody would have told me that 20 years ago, I never ever would have believed them. So I think there is now this critical mass, and it takes a while. We talk about the medical school and we need doctors here. Well, you take 4 years of medical school and then you go ahead and you put them in residency, and that's 3 to 10 years. So homegrown docs take a long time to get here and to get the systems up. So to your point is I think you'll see those stars continue to climb as things go along. I think that right now we're still being challenged by some of the things that we've always been challenged on. The other interesting thing here in Las Vegas, there's always that epidemiological study. There's always black Nevada versus white Utah, right? Because Utah primarily non-drinking, non-smoking, you know, et cetera, et cetera. Here in Las Vegas, lots of drinking, lots of smoking, okay? And that sort of thing. Also, we have about 1 million visitors a year come to town, okay? And they're usually not doing the stuff they do at home here, okay? So oftentimes the morbidity and mortality rates here in Las Vegas and Reno especially, but in Nevada, sometimes don't reflect what is the local population versus the tourist population. So the answer to your question, it's multifactorial. Yes, I think things are getting better and much better, and I think that that will continue to get better, but we can't rest at all. We need folks here coming through our medical schools. We need graduate medical education programs, which thankfully the government, the state government, has been trying to fund more and more of, and also to get more folks into academic medicine as well to really kind of push the envelope. So I hear what you're saying, and yes, it's ongoing, and yes, there's some good docs here, and sometimes, and I've said this before, it takes a tragedy to see that. And I think we saw to the world on 1 October, okay, what happened here in Clark County. Everybody that hit the ER with a heartbeat left with a heartbeat, okay? So, which is absolutely spectacular in a place like this. There has been other mass trauma incidents, et cetera, Boston, et cetera, and unfortunately, we have become an expert, if you will. Didn't see Dr. Cools in the audience. There's lots of folks here that were there on 1 October. We all came together as a city and, moreover, as a medical entity and really showed the world what we are capable of. I think if that word gets out, and I think if people can really see that, we'll get more physicians, more nurses, more techs, more medicine here in the Valley, and I think that you'll see those stars increase. But thank you for that question. Thank you. Please.
So I think I do respect that you mentioned this, and I think we have to accept that we have problems. If we don't accept that we don't have problems, we cannot move. But I will request you, because as you mentioned, that there are lots of things in the Medicare that gives you an aggregate star rating. But I look at this way, that when I work in cardiology, cardiovascular surgery, what I am doing, and I look at the hard endpoints, does my mortality statistics anything worse than my like hospitals? So we do participate in the database, national database, and compare our hospital's performance with like hospitals. If I'm not doing well, then we need to address that. I can assure you that by doing that, we are making things better. And we can say that patients coming with ST elevation MI, what is our mortality statistics compared to, for example, like hospitals in any other city? And also, we will look at, are we doing the right thing? Are we doing the radial intervention, like going from the arm, because it has less bleeding complications and probably more survival benefit. So by doing that, and I will request you that if you look at the wholesale hospital rating versus a area-specific hospital rating, hard endpoints, then you probably will find more encouraging news. And we all are working together to get things better.
Great, thank you. All right. Yes, ma'am.
Hi, I'm from Cox Media. Chris and I here. We realize the importance of recruiting great talent here. We just kind of want to understand more of how we can partner as a media company to do so, and what do those recruitment efforts look like now?
Sure. I think that, and thank you for that question. We at the Clark County Medical Society, and then also our partners in systems, whether it's UMC, whether it's Valley, whether it's a Sunrise system, we're trying to get the word out. We actually, despite the 1-star and 2-star ratings, have a really good system here with really good docs here. And that's been a great, well-kept secret for a long time, minus 1 October. And there used to be a old terrible joke, which I declared dead on my first day of being president, that if you had a bad problem, the best place for medical care is go to McCarran Airport. That is history. I think that we have good docs here. I think we have excellent care here. I think we have cutting-edge technology. And this night is really part of that, getting out that message that we are not stuck in the Stone Ages, that we are actually on the cutting edge. We have new medical schools, we have new medical technology, we have new residences and internships, and guess what? People are flocking to them. So to answer your question is well, how do we get that message out? And so I would defer to you, because I like experts being experts. So I want to know how, a regular doc who is busy going ahead and taking care of patients and doing all the things that he and she do, how do we get that message out? Not just in an echo chamber here in Clark County, but elsewhere. And the Lou Ruvo Center actually is an excellent example of that. People are flying in through McCarran to come to the Lou Ruvo Center. Okay? There's medical tourism, but reverse medical tourism. People are coming to Las Vegas for medical care. Now, if you would have told me that 40 years ago, no chance. But nowadays, we have this story, and we want to get it out. So please go ahead and talk to me afterwards, and I'm happy to brainstorm with you. And again, that's your area of expertise, and I'm happy to go ahead and coordinate with you. And if we can get that out, I think that would be spectacular. And recruit more interested, vibrant minds here to Las Vegas. Because guess what? I'm not getting any younger, okay? So I need all the good medical care I can get, okay? It's stolen from Tom Scully, was a dean of mine. So, all right, one more question. Sir.
Thank you. My name is Mark, My Vegas Magazine. I'm born and raised here since '57, and I've heard all the concerns about having to head out of town if you've got a serious problem. And I heard what you said a few minutes ago, Doc, about the shortage, I guess, that we're having in Las Vegas. And, glory to God, I haven't needed any serious doctors in my life, for any serious problems, I should say, in my life. But if I do, I know that's a very intimate decision one would have to make. It's a personal decision. If there's something going on with their heart and their general practice doctor tells them they've got to see a specialist and they've got to pick one, what, in your opinion, as president and a well-known, respected doctor here, what would be the top 4 or 5 things that one should look for when they need a specialist that you would say what makes a good doctor? I go into the office and I see all the certificates on the wall, but I don't check them out. We don't call the colleges and see if they're how solid they are, or how well they scored. So how does one, the layman, make decisions on what should he base the decisions on in picking his doctor for his emergency?
Right, that's an excellent question. A couple things. How do you pick a good doc? How do I find a good doc? Okay, there's a few places to go first. One is the Clark County Medical Society has a database, and we're happy to go ahead and refer folks to those folks. So that's number one. That's always a good place to start. Going from there, I would then look at board certification. So, and a real board, American Board of Medical Subspecialties. Okay, so whether it's cardiology, whether it's plastic surgery, whether it's colorectal surgery, et cetera, that would be the other place to go is this person board certified in the area that they propose to have expertise in. I would also talk to your family doctor or your internal medicine doctor, because he or she knows you best as well, and they may work well with physicians, and it's a small town still, okay, and so they may very much know who they like to go to refer to. It's very comforting, and we have a cadre of folks in our office that we like to refer to, because you know that your patient is going to get taken really good care of there, and you're going to get feedback from, et cetera, et cetera. So I think those are key areas, and of course there's family and friends, et cetera, but I think starting out there and then going ahead and coning in from there, I think that would be a good place to start, because it can be daunting. You go to the internet and you put up doctor, and 300 people come back at you. So if you can go ahead and start with some of those well-suspected screens and go ahead and start screening down for you, I think you are putting yourself in a position to get a good income, get a good outcome, and to have somebody that really fits you. And the thing is, too, is go see 2 or 3 docs, because especially if it's surgeon, I'm a surgeon, I was a general surgeon, I'm a plastic surgeon, but even my internal medicine friends, my family docs, sometimes you don't click with the guy or gal, and that's okay. There's enough doctors here in town, even though we have a shortage, you can go see 2 or 3 and see who you might go ahead and click with. And that also is important with the office staff, because again, you're going to be having to deal with these folks. So I think it's important for whatever you might have, especially if it's serious, go ahead and get a second or third opinion. No one is offended by somebody says, Doc, I'm seeing 2 or 3 guys and gals because this is important to me. Nobody gets offended by that. And if they do get offended, that's a problem. Then he or she ain't your doctor. Then go ahead and see somebody else. Okay? All right. Excellent question. So again, a couple of thanks, lots of thank yous. Thank you again to the City of Las Vegas for taking the lead in organizing this town hall meeting, which has been proven to be very informative and inspirational about the quality of medical care being delivered to the Las Vegas Medical District. A special thanks to Mayor Carolyn Goodman, who could not be with us tonight. She sent her regrets before we started, and Mayor Pro Tem Lois Tarkanen, who had to go for another engagement, for being with us tonight. Also want a special thanks to our presenters, Dr. Aaron Ritter from Cleveland Clinic, Lou Ruvo Center for Brain Health, that's a mouthful, Dr. Shah with Steinberg Diagnostic Medical Imaging, Dr. Hassan from UMC, and Dr. Browder from the Valley Hospital Medical Center. We enjoyed hearing from each of you and learning more about how technology and innovation is improving healthcare for our community. And I took away 3 or 4 salient points tonight. For those of you interested in learning more about the Las Vegas Medical District, please look at LasVegasMedicalDistrict.com, and there I'm sure they'll have the boundaries for you. This program will also be re-aired on KCLV City Television, Channel 2, throughout the week, beginning on Friday. Also, be sure to stop by the reception. Again, thank you to Valley Hospital Medical Center. It's out in the lobby, so please go ahead, hang out. If speaking for the rest of the doctors, and I shouldn't, but if you have questions, please go ahead, come up to us. We'll be happy to answer any questions that you might have. And again, thank you very much for making it out tonight. I really appreciate that. Drive safe, and then please, any questions, give us a call at the Medical Society. Thanks a lot for coming out.